move to the next talk by Dr. Kaushal Kalra. He is consultant medical oncologist at Advant Hospital, and he will speak on new advent for KATHERINE treatment of HER2 positive residual disease. And this is one area where there's been practice changing things which have happened in HER2 positive arena. Dr. Kaushal, Dr. Kaushal, yeah, good to see you back.
Yeah, hi, Dr.
Yeah. So thank you so much for accepting this, and over to you for the talk.
Yeah, thank you, Dr. Sajjan. Nice introduction. So now I will tell about the new adjuvant for the kadcyla in the treatment of HER2 positive residual disease. So in early, next slide. So KATHERINE rationale. In the early breast cancer, the goal of treatment is cure. Therefore, patients should be given the most efficacious treatment available. Up to 78% of the early breast cancer ultimately relapse. So it significantly impacts the quality of the life of the patient. There is currently no cure for the HER2 positive MBC. So clinical decision point in HER2 positive early breast cancer help to tailor the treatment for the individual's need. Like initial diagnosis for this thing, we have to take into account clinical detail like tumor size, grade, lymph node status, HER2 neo status, hormone receptor status. Then neoadjuvant therapy, goal of the neoadjuvant therapy to reduce the bulk of the disease, to inoperable cancer can be converted into operable, to de-escalate the surgery from the MRM to the breast conservation surgery. And remove this. Third is surgery for the removal of all detectable disease in the breast and the nodes. So pathological assessment of the residual invasive disease to look for the PCR and ultimately adjuvant therapy, elimination of the residual invasive or micrometastatic disease to prevent the metastasis or recurrence in the curative setting. Yeah, please. Yeah, I think it's happened. Yeah, next slide. Hello, I have briefed about this thing, this slide, initial diagnosis, neoadjuvant therapy need for this. Yeah. So based on the current international guidelines, eligible patients with the HER2 positive early breast cancer should receive the neoadjuvant systemic therapy as per the all authentic guidelines like NCCN, ESMO guideline, AGO guideline, and St. Gallen guidelines. So all are saying same thing for the neoadjuvant systemic therapy in the HER2 positive early breast cancer. So for all, because as per all of these guidelines, Perjeta, Herceptin is recommended by all these guidelines. Dual anti-HER2 therapy in the early breast cancer. Next. So prior to KATHERINE, 18 cycles of the Perjeta and Herceptin was the standard of care for the patient with the HER2 positive early breast cancer at the high risk of the recurrence or death, irrespective of the neoadjuvant response. So newly diagnosed case, either they will go upfront for the surgery after that 18 cycles of the dual blockage, Perjeta plus Herceptin, or 4 to cycle of the neoadjuvant therapy followed by surgery followed by the 12 to 14 cycle of the dual blockage. So patient is the same standard of care, whether in the adjuvant setting, whether patient will go into PET-CR or not, regardless of the response to the neoadjuvant therapy, due to the lack of the evidence to support the changing therapy in the early breast cancer in the cure intent, in curative setting. Next. So the presence of residual disease inform a new clinical decision point to the tailored treatment in the adjuvant setting. If newly diagnosed HER2 positive cancer, early breast cancer with more than 2 centimeter in size or node positive, Perjeta Herceptin based neoadjuvant therapy for 4 to 6 cycle followed by surgery, then look for the assessment. If patient in the PET-CR, then continuation of the neoadjuvant therapy like same Perjeta and Herceptin to complete the 18 cycle. If patient has residual disease, so change treatment to this is the new guideline, new standard of care, to change treatment to the kadcyla for the 14 cycle in the adjuvant setting. Similarly, we have seen in TNBC for the no PCR, then we used to give this thing capecitabine. Next. So KATHERINE study design. This is the T1, T4, not 0 to 3 M0 presentation, non-metastatic. HER2 positive early breast cancer, neoadjuvant therapy, minimum 6 weeks, 6 cycle of the chemotherapy, and residual invasive tumor in the breast or axillary node. So patient should not have PET-CR. Then only patient were enrolled in the KATHERINE study. Surgery was done and residual invasive tumor. Then patient was randomized to either Herceptin arm or kadcyla arm for the 14 cycles. So stratification factor was like patient at the clinical stage of the presentation, whether they were inoperable or operable, whether hormone positive or negative, whether patient has received Herceptin or dual HER2/neu. Around 15 to 16% patient only received a pertuzumab in the neoadjuvant setting in the KATHERINE study. Pathological nodal stage were evaluated after the neoadjuvant therapy. Primary endpoint was invasive disease-free survival, and secondary endpoint, the IDFS, second primary non-breast cancer, DFS, OS, DRFI, and safety. Next. So primary endpoint was the same I described, invasive disease-free survival. Secondary endpoint, invasive disease survival as per STEAM definition, including second primary non-breast cancer, DFS, OS, distance elapsed-free interval, cardiac safety, oral safety, and PR. Next. Next slide, please. Yeah, please change the slide. Hello, am I audible?
Aram, please change the slide.
So inclusion, exclusion criteria and inclusion, HER2/neu positive patients confirmed by the central laboratory, histological confirmed, breast cancer, completion of the more than 6 cycle of chemotherapy. I have this thing described, surgical removal of the all clinical evident disease, pathological evidence of residual invasive carcinoma in the breast or axillary node, known hormone receptor status, and ECOG PS 0 to 1, and ejection fraction must be more than 50%. In exclusion, all metastatic disease and which are not included in inclusion. Next, please. So study populations were well matched, around in randomized IT2 population, 743 in each arm, and around 722 patients treated in Herceptin arm and kadcyla 40 arms, and follow-up was around 3.5 years. Crossover was from the kadcyla to the Herceptin was in 71 patients. Next slide. Yeah, please change the slide. So in summary, the early breast cancer treated as a curative intent, patient should receive the recommended duration of the most efficacious available treatment as early as possible to prevent the of the neoadjuvant. Despite the proven benefit of the neoadjuvant HER2 targeted treatment, patient with the HER2 positive breast cancer is still at the risk of recurrence, particularly those who are not attained PET-CR or those with the residual invasive disease. So the aim of the phase 3 KATHERINE study was to investigate whether the adjuvant kadcyla improves invasive disease survival compared with the Herceptin arm or not. This was the only aim in the KATHERINE study. Next. Next. So stratification factors were well balanced between the treatment arm, including inoperable, operable, almost well matched, hormone receptor status, neoadjuvant HER2 target directed therapy. As I mentioned, around 19 to 20 patients in Herceptin arm and 19% kadcyla arm patient received additional HER2 agent along with the Herceptin. And other like pathological nodal status was evaluated after neoadjuvant therapy. These are also almost well matched. Node positive are 46% in both arms, and node negative are 53% in both. Next. Baseline demography were also well balanced between the both arm, like age, race, and the region. Next. Similarly, extent of the residual invasive disease, including PATH-CR, pathological node status at the time of surgery, was balanced between the both arm. Primary tumor stage at definite surgery and regional lymph node stage at the definite surgery, both are almost well matched in both arms. Next. Similarly, patient who received prior anthracycline and prior neoadjuvant therapy were well matched. Around 75% patient in Herceptin arm and kadcyla arm, 77% received prior anthracycline. Similarly, around 18% in Herceptin arm and 18% in kadcyla arm received both pertuzumab and Herceptin both. Around 80% patient had only received Herceptin in the neoadjuvant arm. So the IDFS was the primary endpoint, and KATHERINE met its primary endpoint, reduced the risk of IDFS event by 50% compared with the Herceptin at a median follow-up around 41 months, 3.5 years. You can see 3-year IDFS was 88.3% in kadcyla arm, while it is 77% in the Herceptin arm, almost benefit of the more than 11%. So kadcyla increased the 3-year IDFS rate from 77 to 88.3%, which is statistically significant with hazard ratio of 0.5. Next. The magnitude of IDFS benefit in all subgroup are consistent with the ITT population. In all subgroup, you can see whether patient were inoperable or operable, whether ERPR negative or hormonal positive, whether. But except in this, when this Herceptin and pertuzumab both were given, then it is not significant. Otherwise, in Herceptin alone, it's significant, whether it's not positive, not negative, and in early age, less than 64 years, almost in all subgroup, it's a statistically significant. Next. The majority of recurrence were distance with a reduced incidence in the kadcyla arm. We can see around it was 22% in the Herceptin arm, but while in the kadcyla arm, it's around 12% total patient with the IDFS event. In distant recurrence, it's almost benefit of the 5 to 6%, 15.9% in Herceptin arm, 10.5% in kadcyla arm. So all recurrences, there is reduced incidence in the kadcyla arm. Next. In secondary endpoint, fewer distance recurrence with the kadcyla versus Herceptin at the first interim analysis, around 40% reduction in the distance recurrence with the kadcyla. Next. So OS data are still not mature, but supportive in the of the primary endpoint, and maybe this may separate more when data will be mature. Next. So in efficacy summary, KATHERINE met its primary endpoint, significantly reduced the risk of breast cancer recurrence in the patient with the residual invasive disease who have not achieved the PATH-CR after neoadjuvant therapy compared to Herceptin only. kadcyla reduced the risk of invasive disease survival by 50%, or 3-year IDFS was increased by almost 11.3%. So kadcyla demonstrated consistent IDFS benefit across all patient subgroup, including hormone positive, node positive, and prior dual HER2 blockage, and was irrespective of the amount of residual invasive disease and concomitant radiotherapy. Kadcyla should not be withheld in patient with the HER2 negative residual disease at surgery. Prior to surgery, it was positive. After surgery, sometime happened, it's negative. So it should not be withheld. Efficacy benefit of kadcyla were maintained across the key secondary endpoints. OS data are immature at the clinical cutoff, with only 98 events only occurred till now. Next. So now come to the safety data in primary analysis. So different adverse events are more in the kadcyla arm, but only major are only generally low grade, manageable, and easily monitored, like fatigue, nausea, thrombocytopenia, transaminitis, headache, radiation in skin injury. Next. But grade 3 adverse event, only significant thrombocytopenia. It was the major concern for the clinician in around 3.6% patient, and transaminitis is also 0.5, but clinically day-to-day practice we have seen. And I have seen in my clinical practice around 5-6 patients had infusion reaction, including one patient had grade 5 reaction, patient expired. But in that case, generic molecule was given, biosimilar, not original Roche molecule, kadcyla. So I have seen this infusion reaction more in that generic version of biosimilar of that kadcyla. Next. So overall safety data in KATHERINE are consistent with the known safety profile of kadcyla. There are high rate of discontinuation rate in kadcyla arm, around 18%, compared with the herceptin arm, in which it was only 2%. Most common adverse event leading to kadcyla discontinuation was laboratory abnormalities, include low-grade asymptomatic, and which are low-grade asymptomatic and reversible. Prior platinum therapy was associated with increased incidence of thrombocytopenia and kadcyla, but did not affect the duration or resolution of the grade 3 to 4 thrombocytopenia. Peripheral neuropathy duration and resolution rates are comparable between treated arm, regardless of baseline peripheral neuropathy. Baseline level of physical and cognitive function and this quality of life were maintained over the course of treatment. There was no clinically meaningful deterioration in the treatment arm. The lack of meaningful difference in average score at each assessment says that kadcyla was tolerated with little impact on function or global quality of life of the patient. Next. So treatment algorithm for the patient with the HER2 new positive early breast cancer, newly diagnosed. If it is T2, the more than 2 centimeter size or node positive, pH-based regime, 4 to 6 cycle, followed by surgery. If patient achieves PATH-CR, then we have to continue pertuzumab with Herceptin for the total of 18 cycle. If patient did not achieve PATH-CR, residual invasive disease there, then we have to give kadcyla for the 14 cycle. This is the standard of care. If patient has only T1, clinical T1, 0 and 0, then surgery upfront. If node positive, pH-based regime. If node negative, then only TH, Herceptin plus taxane can be given. So prior to KATHERINE, all patients at a higher risk of recurrence received 18 cycle of pertuzumab and Herceptin, regardless of the timing of the surgery. KATHERINE now offer a tailored approach based on the neoadjuvant treatment outcome. So it's the standard guideline for the all. It has been adopted by the all standard guidelines, NCCN, ESMO, AGO, St. Gallen guidelines. Next. 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 Come to next slide. Yeah, it's the same. The use of neoadjuvant therapy enable response directed therapy in the adjuvant setting. Same I told. So patient who have a PATH-CR after pH-based neoadjuvant therapy still at a risk of recurrence for death or should receive pH in the adjuvant setting to complete 18 cycle. Till now. Now it has been changed. Next. Come to the summary. Next slide. Next. Come to the summary. Yeah. Yeah. So KATHERINE has introduced a new decision point in HER2 positive early breast cancer. Adjuvant treatment should be optimized based on the response to neoadjuvant therapy. Patient with any amount of the residual invasive disease after HER2 directed neoadjuvant therapy should receive 14 cycle of kadcyla in the adjuvant setting as recommended by the international treatment guidelines. Those who achieve a PCR after HER2 directed therapy still have a risk of relapse should continue with the pertuzumab Herceptin to complete the 18 cycle in adjuvant setting. So the key message is, next slide, KATHERINE marks a new standard of care in the patient with the HER2 new positive early breast cancer. Early breast cancer treatment is the same I have already explained. So key point, KATHERINE marks a new standard of care for patient with HER2 new positive early breast cancer. So that's all. Thank you.
Thank you, sir. Thank you, doctor, for your nice presentation. So Dr. Sajjan sir is there?
Yeah, I'm here, Ikaji.
Yeah.
So,
Yeah. So
okay. So after these wonderful presentations from my esteemed speakers, we like to move to